Good evening, all. So today we'll be discussing on some miscellaneous topics in orthopedics. Last session we discussed about bone tumors. Today we will be touching on metabolic, congenital, a little bit of trauma like that. So we will start the session. So first question is a 6-year-old boy is brought to the OPD with history of painless limbing right side for 4 months. So the history is painless limbing. You know what is limbing means? Any abnormal gait is called limbing. So he's having a painless limbing on the right side for 4 months. On examination, there is a flexion deformity, adduction deformity, and external rotation deformity of the right hip. So whenever you hear the term deformity, that means the opposite movement is not possible. For example, flexion deformity means it's implied that extension is not possible. Adduction deformity is adduction deformity means abduction is not possible. External rotation deformity means internal rotation is not possible. So this is a classical deformity: flexion, adduction, external rotation. So in orthopedics, we have to know about certain deformities. If you know the deformities, you can, and if you know the age of the child, you can get a diagnosis. So flexion, adduction, external rotation deformity is classical of Perthes disease in a child. Whereas if you see flexion, adduction, external rotation in an adult or an what do you call, in a middle age or a old, especially suffering from arthritis, it is nothing but osteoarthritis of the hip joint. Whereas if you hear flexion, adduction, and internal rotation, in other ways, we usually refer to as FAIR, F-A-I-R, flexion, adduction, internal rotation. That is not with history of trauma as well. You have to think of posterior dislocation of the hip joint. Another deformity is flexion, abduction or abduction, and external rotation deformity. That is, with history of trauma, you have to think of anterior dislocation of the hip joint. That is called, in short form, we usually describe it as FABEX, F-A-B-E-X. So if it is FABEX, it is anterior dislocation. FAIR, F-A-I-R, flexion, adduction, internal rotation, it is posterior dislocation. Flexion, adduction, external rotation in a child, usually it is Perthes disease. And flexion, adduction, external rotation in adults and old, it is osteoarthritis of the hip joint. So that point should be very much clear. So that should be clear. Then only we can get the diagnosis. So here the answer is Perthes disease. You know, Perthes disease is named after George Perthes of Germany. Actually, it is called LCP, leg calf Perthes. 3 different people from 3 different countries actually describe the same disease. So it is called leg calf Perthes, leg from Boston, calf from France, and Perthes from Germany. So it is nothing but an avascular necrosis. You know what is avascular necrosis? That is nothing but loss of blood supply to the femoral epiphysis. Epiphysis means the capital epiphysis. That means the femoral head is not vascular. So the vascularity is compromised. So there's a big difference between avascular necrosis in a child and in an adult. You know, in avascular necrosis in a child, it can be self-limiting. That means it can resolve by itself. Only a few percentage it may lead on to deformities and arthritis. Whereas if avascular necrosis occurs in adult, definitely it won't be self-limiting. That means it will definitely progress to arthritis. So that is the difference between a Perthes disease in a child and avascular necrosis in an adult. You know, avascular necrosis, the most common cause in adults, in males especially, is alcohol. Alcoholism is the main cause. Whereas in female adults, it is steroid use. Usually following steroid use in collagen vascular disorders, rheumatoid arthritis, SLE, like that. So that is the difference. So when avascular necrosis occurs in an adult, it will never resolve by itself. It will definitely progress to arthritis. So, but what happens avascular necrosis in a child? Definitely, in some cases, it may resolve by itself. So the answer is Perthes disease. So I have already told it is a leg calf Perthes disease. It is otherwise called pseudocoxalgia. Actually, algia means pain. It's actually, even though we call it as limbing, it's actually a painless limbing. That's called it's a pseudocoxalgia. And coxa plana. Coxa, the word means hip joint. Plana means it's flat. The head may be flat. The architecture of the head may be lost. It may be mushroom shaped. It may be coxa magna. It can be even irregular. So it can be called coxa irregularis. So whenever you hear the term coxa plana, coxa magna, coxa irregularis, it often refers to Perthes disease. And it is the most common type of osteochondritis. What do you mean by osteochondritis? It is nothing but avascular necrosis. And one more thing to add is sometimes it may be referred to as coxa breva. You know what is coxa means? Hip joint, and breva means short. So coxa magna means large head, whereas coxa breva means short neck. So doesn't mean that it's small head, it's short neck. So that's the difference. Coxa magna means large head and coxa breva means short neck. All these terms are described for Perthes disease. That means short neck, large head. These are all seen in Perthes disease. And it affects the capital femoral epiphysis between 4 and 8 years. That's very important. That's the importance of vascular anatomy. That means the blood supply to the femoral epiphysis is different in different age groups. That means less than 4 years, actually, the lateral epiphyseal artery as well as the metaphyseal arteries supply the capital femoral epiphysis. That means two vessels. That means the lateral epiphyseal artery and the metaphyseal artery. The metaphyseal artery usually crosses the physis to reach the epiphysis. What happens after 4 years? The physis, the physis is the growth plate. The growth plate will be well formed after 4 years in a child. So it will act as a barrier so that it will never allow the metaphyseal vessel to cross the physis to reach the epiphysis. So only one artery, that means the only feeder of the femoral capital epiphysis between 4 and 8 years is nothing but the lateral epiphyseal artery. So what happens after 8 years? Another vessel will start growing through the ligamentum teres. That is nothing but the medial epiphyseal artery, or otherwise called the artery of the ligamentum teres. That appears, say, after 8 years. And in blacks, in black population, in blacks, the artery of the ligamentum teres or the medial epiphyseal artery actually comes a little bit earlier than the other population. So that means it may even appear at 7 years like that. That means the incidence of Perthes disease is very less among blacks. The reason is because of the early appearance of the medial epiphyseal artery, or otherwise called the artery of the ligamentum teres. Of course, there is an association with the human leukocyte antigen, the HLA, also for Perthes disease, and it is actually HLA-A1. So this is in short about the blood supply of the femoral head, the capital epiphysis. This is the epiphysis, and this white thing is the growth plate. I told you it is almost fully formed after 4 years, and this is the neck, and these are the lateral epiphyseal artery, and the metaphyseal artery cannot cross the physis to reach the epiphysis after 4 years. So what happens when the physis is closed after, say, 16 to 18 years? All the three vessels, the lateral epiphyseal artery, the medial epiphyseal artery, and the metaphyseal artery, all the three will supply after physis is closed. That means after 16 years. So this is the artery of the ligamentum teres or the middle epiphyseal artery. So this is in short about the femoral head blood supply. And the major feeder is coming from the medial circumflex femoral artery, which is actually posterior, and the lateral circumflex artery, which is anterior. They form a ring, and from there the vessels arise. Okay. Then a very important sign in Perthes disease is Waldenstrom sign. So what is this Waldenstrom sign? Here you can see that in Perthes disease, there is actually widening of the joint space. So here you can see the joint space is widened when compared with the right side. The joint space is widened. That is classical of early Perthes disease. Why? Because due to the effusion, synovial effusion is one of the reasons, and the other reason is actually congestion of the ligamentum teres. And of course, another reason is actually hypertrophy of the articular cartilage. Cartilage is actually radiolucent. So one more thing to add is in Pathy's disease, the head size actually may be big. Why? Because the cartilage will definitely overgrow than the bone. Why? Because the when the blood supply is compromised, the bone will not grow, but the cartilage will grow. Why? Because the cartilage gets the nutrition from the synovial fluid. So whenever there is relative hypertrophy of the cartilage, it will be seen as radiolucent. So it is seen as widening of the joint space, especially on the medial aspect. How will you know that this is the medial aspect? This is the teardrop and the femoral epiphysis. This distance will be wider. This is called Wallenstrom sign, and that is seen in Pathy's disease. Another sign that is seen in Pathy's disease is sagging rope sign. Here you can see something like a sagging rope. That is nothing but an overlap of the femoral epiphysis with the metaphysis. So this is a beautiful sign that is seen in the healed stage. So when you are asked where is Waldenstrom sign seen, that is seen in early Pathy's disease, where a sagging rope sign. It is marked by a black arrow. Here you can see this is one. It's a radiodense line overlying the proximal femoral metaphysis. Actually, an overlap. You can see that the femoral head is actually overlapping the metaphysis. That is seen in advanced stage or healed stage. So that is called a sagging rope sign. So how will you manage Pathy's disease? Usually, in older days, we used to manage it conservatively by broomstick plasters, or otherwise called Petri cast. This is actually nothing but something like a broomstick. It looks like the broomstick, and it's called a Petri cast, and the hips are kept in wide abduction, say around total 60 degrees of abduction, abduction, and internal rotation. You know why? What happens when you abduct the hip and internal rotate the hip? You are actually containing the hip. What do you mean by containing? Containing means already in Pathy's disease, there is lateral subluxation, extrusion of the femoral head from the acetabulum. So your aim is to contain. So the word containment is very important. That is the principle, the main principle of treatment of Pathy's disease. That means you put the head back into the acetabulum by abducting and interrotating. So whenever you abduct and interrotate, the head goes back into the acetabulum. So that what happens is that the abnormal head, when the architecture of the head is lost, when it is actually articulating with the normal acetabulum, the acetabulum will beautifully shape it back into the normal shape, and that is called the biological plasticity of the acetabulum. Okay, so a surgery that can be done is called axis osteotomy. That is nothing but a varus derotation osteotomy, sometimes called an axis osteotomy. And that's nothing but you do an osteotomy at the level of the below the trochanteric level, that's the subtrochanteric level, and actually you try to adduct and actually you try to external rotate the femur. So what happens when the limb is adducted and external rotated, the child cannot walk, and you fix the osteotomy with plate and screws. So what will the patient do? The patient will try to abduct and interrotate. So thereby containing the head back into acetabulum. So that is called axis osteotomy or varus derotation. Why you are giving it in varus means, so if you are giving it in varus means adduction means the patient cannot walk in varus. So the patient will purposefully abduct and internal rotate also. You are actually keeping it in varus and external rotation. That is called derotation. So the child, when the child starts to walk, he will do it in the opposite manner. That is abduction and rotation. So that will contain the head back in the acetabulum. So coming to the next question, a 14-year-old boy is brought to the OPD with a history of painful. Here you can see it's a painful limbing on the left side. The general examination, the patient is obese with absence of secondary sexual characters, and on examination, joint line tenderness and left hip extension deformity and a adduction deformity and external rotation deformity. So the deformity is entirely different from Pathy's disease. In Pathy's disease, it was flexion, adduction, and external rotation. Here, it is extension, adduction, and external rotation. So here it is not flexion. So with axis deviation and true short. You know what is axis deviation? Axis deviation means when you actually flex your uh, hip and knee, it actually points to the towards the opposite shoulder. But in extra rotation deformity, when you flex your hip and knee, it will actually go to the or same side. That is called the axis deviation. That means normally when you flex your hip and knee, you actually take your knee to the opposite shoulder. But in external rotation deformity, it will not go to the opposite shoulder. It will be going to the same shoulder only. That's called axis deviation. And there'll be true shortening also. The condition is very simple because there is loss of secondary sexual characters, obese child. Loss of secondary sexual characters means nothing but hypogonadism. The testosterone or estrogen is less. Then obese means definitely the growth hormones, somatomedins, they are on the higher side. So basically an endocrine abnormality is also involved. And the left side, the answer is slipped capital femoral epiphysis. So this is called a slipped capital femoral epiphysis. So it's otherwise called SCFE or adolescent coxa vara. And it is more common in males. The age group is 12 to 14 years, and if it is seen in females, it is 10 to 12 years. And it's more common on the left side. And actually, the term is a misnomer. It is not the epiphysis that slips, it is a metaphysis that is slipping. So actually, it's a misnomer. Even though it is called the slipped capital femoral epiphysis, the epiphysis is not actually slipping. The metaphysis is actually slipping anteriorly and superiorly. So relatively, the epiphysis is slipping posteriorly and inferiorly. That is the difference. Then the most common endocrine abnormality associated with slip, especially bilateral slip, is hypothyroidism. So that is very important. So you should remember about the different endocrine issues associated with slip. The most common is hypothyroidism. Then comes increased somatomedins and growth hormones. Then decreased sex hormones. Then there can be hyperparathyroidism also in slip. So remember, even in chronic renal disease or renal osteodystrophy, there can be secondary hyperparathyroidism, and that can cause slip. Even radiation can induce slip. So there are a lot of reasons for slip. So histologically, the hypertrophic layer of the growth plate enlarges. So when the hypertrophic layer enlarges, what will happen? It is mechanically weak and the metaphysis slips over the epiphysis. Even though you call it as slipped epiphysis, it is actually metaphysis. So next slide. So here you can see that the epiphysis is actually not slipping. It is actually in place only. So the metaphysis is slipping anteriorly and superior. So relatively, the epiphysis is slipping posteriorly and inferiorly. So here you can see a moderate slip of the SCFE. And some radiological features are there. If you want to see here, you can see there is definitely widening of the physis. That can be seen a loss of epiphyseal height. The epiphyseal height will be shortened and it looks like a sickle. That's called a sickle sign. The shape will be, the height will be less. That's called sickle sign. And the widening of the physis, if you are asked, the earliest finding in slipped capital femoral epiphysis, the radiological finding is it is a rarefaction at the physis and widening of the physis. And there's another sign called the metaphyseal blanch sign of Steele. Like in Pathy's disease, also here you can see there's an overlap of the epiphysis with the metaphysis, and that is called the head on the metaphysis or the metaphyseal blanch sign of Steele. Then another sign called Trithoven's sign. You draw a line along the superior aspect of the neck. Normally, it cuts a portion of the epiphysis, but in what happens in slip, because the metaphysis is anterior and superior, the line will not cut the epiphysis, and that's called Klein's line or Trithoven's sign. And another sign is called Capiner's sign. Capiner's sign means normally, the metaphysis will overlap with the floor of the acetabulum. But in slipped capital epiphysis, since the metaphysis is slipped, it will not overlap. And that is called Capiner's sign or sham sign, SHAM. So we will see it here. So here you can see that on the right side it's normal, whereas on the left side you can see a slippery capital femoral epiphysis. So the radiological features are very evident here. You can see widening of the widening of the physis, and that is one of the earliest findings in slip. So widening and rarefaction, and this is the cleans line. When you draw a line along the superior border of the, what do you call, the neck, and it is not cutting the epiphysis, but what happens here, when you draw a line along the superior border, it will, here it is cutting, here it is not cutting. And not only that, the medial metaphysis, it is overlapping with the floor of the acetabulum on the normal side here, but on here the metaphysis is out. So it is not overlapping with the floor. So capillary sign is positive, like that. And not only that, the head looks like a sickle, and the epivasal height is less. That's called sickle sign. So a lot of signs are described in slip. And coming to Truthoven sign, here we already discussed. This is a clean line, and it is not cutting. So the treatment of slippery capital femoral epiphysis is actually in situ fixation. That means in mild to moderate slip and all, you don't reduce the slip. Why? Because if you reduce the slip, there is always a chance of avascular necrosis, and you will be making the head worse. I mean, in future, the patient will develop arthritis. So you don't want that. So what will happen? You accept the slip and you do in situ fixation. What do you mean in situ? Means the slip is accepted and you you fix it with a single cancellous screw. Why you want to fix it with a cancellous screw? Why? Because the threads of the screw will crush the physis, and that will lead on to premature closure of the physis. That means your aim is early physial arrest. That means you want to close the physis at the earliest so that further slip is prevented. So that's called in situ fixation. The treatment is actually in situ fixation with a single cancellous screw. And the complications of slip are avascular necrosis and actually chondrolysis. What is chondrolysis? The word chondro means cartilage. Lysis means completely degraded. That happens if the screw length is more, if you put multiple pins, or the screw length is more, if it is going out of the cartilage, it may erode the cartilage, and that causes chondrolysis. So two complications are chondrolysis and avascular necrosis. So coming to another osteochondritis, we already discussed about slippery capital epiphysis, Perthes disease, like that. This is another osteochondritis, and that is called Sever's disease. So Sever's disease actually affects the calcaneal apophysis. So here you can see the calcaneums. The calcanea has got an apophysis. There are 4 types of epiphysis. One is a pressure epiphysis, another is a traction epiphysis, another is a aberrant epiphysis, and a pressure epiphysis. So here apophysis is actually a traction epiphysis. It is due to the pull of the tendon Achilles, so it is called the apophysis, like your tibial tuberosity, greater trochanter, lesser trochanter, like that. So here you can see some sclerosis over the apophysis, and that is called some fragmentation also. So this is called Sever's. Sever's actually affects the calcaneum. So remember, so a lot of osteochondritis have been described. We have to remember the different osteochondritis depending on the site. The most common osteochondritis is leg Perthes disease, which classically affects the capital femoral epiphysis, and Colles disease affects the navicular bone. That's very good, navicular bone. And Kienbock's disease, it is the lunate. So Kienbock is a very common avascular necrosis in the wrist, and we often see Kienbock's disease. And Pricer is also an avascular necrosis of the proximal pole. The blood supply of the scaphoid is usually from distal to proximal. So whenever there is a fracture of the waist of the scaphoid, usually the proximal pole will suffer avascular necrosis, and when it is avascular and sclerotic, we call it as actually Price's disease. And what about Sinding-Larsen-Johansson disease? That is nothing but the osteochondritis of the lower pole of the patella. It's lower pole of the patella. And Osgood-Schlatt's disease is nothing but osteochondritis of the tibial apophysis. I already told it's due to the pull of the ligament patella. It's again apophysis, tibial tuberosity. Then calves disease. So don't confuse leg calf with this calf. This is different. Calf disease is actually a ring apophysis. The vertebra develop some ring apophysis, and that's called a ring vertebral ring epiphysis, and that disease is called a calf's disease. Then Panner is actually a osteochondritis affecting the capitulum, the humerus, and Iceland's disease is actually a osteochondritis affecting the base of the fifth metatarsal. So you may often mistake it for a Jones fracture, especially in a child. You may see that it is uh, a loose fragment like that, but it is actually an apophysis. And Freeberg's disease is nothing but avascular necrosis of the head of the second metatarsal. So you have to remember all these things. Then achondroplasia, it is characterized by all except. So, achondroplasia means A means no, chondro means cartilage plasia. So, there is a defect in the cartilage growth. So, that is a important cause of a rhizomelic dwarfism. There are three types of dwarfs: rhizomelic, mesomelic, and an acromelic. Melia means limb. Rhizomelic, rhizo, the word means proximal. Meso means middle, and acro means distal. So, achondroplasia is a very important cause of a rhizomelic dwarfism. That means the proximal bones on the proximal limbs are short. For example, the humerus is short, the femur is short. So, it is actually it is an autosomal dominant condition within variable in penetrance. And there will be a lumbar canal stenosis that is classical of achondroplasia, and there will be canal stenosis, and the interpedicular distance will decrease as you come from cephaloid to caudal direction. Then the classical hand described in achondroplasia is trident hand because of the big gap between the what do you call the middle and the ring finger. But the intelligence quotient IQ will be normal. So mental retardation is not seen in achondroplasia. So answer is C. So achondroplasia is the most common form of dwarfism, and it is a autosomal dominant with actually a result of spontaneous mutations, and it is actually a point mutation, the gene fibroblast growth factor 3. It is actually located in, and it can be mapped to chromosome 4p. So that is in the short arm of chromosome 4. So it is actually a fibroblast growth factor 3. And it is a rhizomelic. Rhizo means root, the proximal part of the limb, with humerus and femur affected more than the distal extremities. And the patient will be having a typical trident hand. Why? Because of the gap I already told between the ring and the middle finger. And the inner pelvis, the shape is actually described as a champagne glass appearance because of the inner pelvis looks like the champagne glass. And the radiological hallmarks is actually the progressive narrowing of the interpedicular distance as one measures from cephaloid to caudal. So what happens when the interpedicular distance decreases? The canal stenosis, and patient may suffer from neurogenic claudication due to lumbar canal stenosis. So here you can see the actually a big gap between trident hand and short humerus, and this is a classical achondroplasia. Here also you can see the femur is short and the proximal bones are short. Then another is Q ankle. Q, the word actually it represents the quadriceps. So if you know that Q is quadriceps, it's very easy. It's actually used in the diagnosis of recurrent dislocation of patella. So it's actually Q means actually the quadriceps pull. So that's the thing. So that is used in the diagnosis of recurrent dislocation of patella. Okay. So that is the answer. And Q angle is actually formed by the line of pull of the quadriceps and that of the patellar tendon as they intersect at the center of patella. Normally, Q angle is around 8 to 10 degrees in males, and like carrying angle, Q angle is also more common, more in females, around 15 to plus or minus 5 degrees. So it's almost 5 degrees more in females than in males, and it actually due to the wider pelvis. So here you can see this is the Q angle. You draw a line from the anterior superior spine to the center of patella and from the center of patella to tibial tuberosity. And you then join another line from the center of patella to the vertical and you take the smaller angle. Normally it's around 8 to 10 degree in males and 15 degree in females. So what happens in the recurrent dislocation of patella, a lot of factors which can increase the Q angle. So when the Q angle is more, it will actually pull the patella laterally. So that will actually contribute to patellar dislocation. So a lot of conditions are there, including genu valgum. So when the genu valgum, when the leg is abducted, that means there is outward deviation of the leg at the knee. Then increased femoral anteversion. You know what is anteversion? Meaning your femoral neck is not actually in the same coronal plane of the shaft of the femur. It is actually around 12 to 15 degrees anterior to the coronal plane or the transcondylar axis of the femur. So when the femoral anteversion is more, definitely the Q angle will also be more. Why? Because the limb will be more externally rotated, and external tibial torsion also contributes to Q angle. Why? Because the tibial tubercle will be externally rotated, and lateral position tibial tuberosity. And when the lateral structures are tight or when the medial structures are lax, again it will contribute to increase Q angle. Then coming to iliac horns. So iliac horns are actually seen in which condition? That means the radiologically you will see something like horns over the ilium. That is actually seen in nail patella syndrome. Nail patella means both nail and patella will be dystrophic, and even there will be absence of nail and patella. That's the thing. That's called hereditary onychosteodysplasia. So it's a genetic disorder that results in small or poorly developed nail and patella. Even there can be absent nail and patella. So it is otherwise called iliac horn syndrome. Why? Because the majority of the patients with the nail patella syndrome will have iliac horns. So it is otherwise called a hereditary onychoosteo. Onycho means nail and osteo means bone. So both are dysplastic. The other is also other synonyms are Fong disease or Turner Kaiser disease syndrome also. So here you can see some exostosis arising from the posterior aspect of the ilium here. So these horns are called the iliac horns, and they are classically associated with nail patella syndrome. So what are Wormian bones? Wormian actually, old worm is actually is a name of a person, Olwom. He was an anatomist and is a Danish anatomist, and he actually described the Wormian bone. Actually, Wormian bone are actually intersutural bones. So extra bones seen between the sutures in the cranium. And a lot of conditions are. Wormian bones are seen in a lot of conditions, including Down syndrome, cleidocranial dysostosis. Cleidocranial means there is a even patient may not have clavicle, and there will be deficiency of the some dysplasia of the cranial bones like that. And fragilitas osseum is nothing but glass bone disease or osteogenesis imperfecta. That's a very important thing. That's very common also. Osteogenesis imperfecta is nothing but the osteogenesis is not perfect. Why? Because the bone looks like glass bone. Other is called fragilitas osseum. Fragilitas means brittle, or other is called brittle bone disease or Lobstein's disease or Rolich's disease like that. Nothing but the thing is there's a defect in the type 1 collagen. So there's a gene that codes for the type 1 pro-collagen, and what happens in osteogenesis imperfecta is that a type, there are around 13 types of collagen in your body. The type 1 collagen is found in bone, tendon like that, and type 2 in the cartilage. So type 1 cartilage is when it is deficient, definitely bone strength will be less and the child will get repeated fractures, and the sclera will be blue, and that syndrome, Van der Hoef syndrome, where there will be autospongiosis with blue sclera with osteogenesis imperfecta. So in all these conditions, Wormian bone will be seen. So actually Wormian bone is actually nothing but an intersutural bone, and it is seen in a lot of conditions. If you want to remember, you can remember this mnemonic, the pork chops. where you can see pycnodysostosis. Osteogenesis imperfecta is otherwise called fragilatus ostium. Rickets in the healing phase, you may see in the sutural bones. Kingy hair syndrome, cleidocranial dysplasia, even in hypothyroidism, hypophosphatasia, then autopalato-digital syndrome, then primary acrosteolysis, and even in Down syndrome. Then Sayle's gait. You know what is Sayle's gait? Sayle's gait means actually the way the sailors walk. They actually, it is called a duck waddling gait. They sway on either side. Usually, that's called a bilateral Trundleberg gait. You know what is a Trundleberg gait? In Trundleberg gait, the patient will limp with lurch. You know what is lurch? Lurch means sway to one side. So in Trundleberg gait, the patient will limb with lurch to the same side. That means they sway to the body to one side. In Sayle's gait, it is called a bilateral Trundleberg gait. That means that the patient will be swaying to both sides, and that is seen in bilateral CDH. You know, bilateral CDH means the what happens in CDH, the fulcrum is gone. So remember, Trundleberg gait is seen where the fulcrum, the liver arm, or the power is gone. The fulcrum is the hip joint. The liver arm is head, neck, and trochanter. So even in head, fracture the head, neck, trochanter, there will be Trundleberg gait. And when the power is gone, for example, gluteus medius, superior gluteal nerve palsy. Again, and the what do you call the abductor mechanism will be gone, and the patient will get a Trundleberg gait. So the answer is bilateral CDH, you will get Sayle's gait. And what about coxa vara? In coxa vara also, which thing is gone? It's not the fulcrum, but the liver arm is gone. Why? Because the neck shaft angle is less than 100. So the answer is both A and B. Why? Because in both conditions, in CDH, the fulcrum is gone. Why? Because the head is dislocated, and coxa vara, the neck shaft angle is decreased. So it's a bilateral Trundleberg gait. So various other gaits are described. The most common gait abnormality is antalgic gait, where it's a painful gait. It's commonly seen in osteoarthritis or synovitis or any painful condition. The Trundleberg gait, classically in CDH, in other you can also see in the other hip dislocations. Again, in what you call a coxa vara and gluteus medius palsy, superior gluteal nerve injury, like that. And even in non-union neck of femur when the fulcrum is gone. Then hand-on-knee gait, usually in cortices palsy, the locker of the knee is actually the vastus medialis obliquus muscle, and the unlocker of the knee is popliteus. So when the patient is having a weak cortices, the patient is not able to lock the knee. So patient will advertently use his hand to lock the knee. So you might have seen people walking with their hands on knee gait, and that is classically seen in poliomyelitis, that is post-polio residual paralysis. Then scissoring gait is in cerebral palsy, because of the spasm, and there will be, especially the adductor spasm, there will be scissoring. And high stepping gait is in CPN, the conperoneal nerve palsy, where there is foot drop, so the patient won't be able to clear the foot off the ground. So he, of course, the patient flexes the hip and need to clear the foot off the ground. That's called high stepping gait, that is seen in common peroneal nerve palsy. Then teriparatide, that is a very important drug. Actually, it's a novel drug used in the management of osteoporosis. Actually, it is a hormone. The answer is osteoporosis. So this is actually a 34 amino acid sequence of the parathormone. Parathormone is actually a hormone, and it's a protein. It consists of around 84 amino acids. Of the 84 amino acid sequence, you take the first 34 amino acid sequence, and that is called the teriparatide, which actually stimulates the osteoblast. Actually, it is an anabolic anti-osteoporotic drug. Parathormone, actually, what is the action of parathormone on bone? It actually mobilizes calcium from bone to blood. It causes hypercalcemia and hypophosphatemia. That means it actually causes resorption of bone. But what happens when you take the first 34 amino acid sequence of the parathormone and you give it in a pulsatile manner? That means every day you give it, every 24 hours you give A small dose of 20 micrograms, it actually, even though it stimulates the osteoclast, it indirectly stimulates the osteoblast also. So, in effect, it is not actually a catabolic drug, it is actually an anabolic drug, and it is very useful in osteoporosis. And the dose is around 20 micrograms subcutaneous daily. It is available in pen preparation like insulin, but the thing is a little costly, and it can be given for even up to 2 years. So that is actually the drug of choice in type 2 osteoporosis. You know what is type 2 osteoporosis? Type 2 is actually senile osteoporosis, and type 1 is postmenopause. Postmenopausal is means both uh, osteoblastic and both osteoclastic activity are high. So in type 1 osteoporosis, you actually give bisphosphonates, calcitonin like that, but because you give actually anti-catabolic drugs. Whereas in type 2 means both blastic and clastic activity are very low. So basically you give teriparatide. So the only main risk of teriparatide is the risk of osteosarcoma, especially the patient is having Paget's disease. So that's very important. You have to screen the patient for you just check the alkaline phosphatase level, and if it is raised, you have to rule out Paget's disease, and the patient is having Paget's disease. Don't give teriparatide. Why? Because it can actually convert Paget's disease into malignant, what do you call the osteosarcoma. I think in the last session we have discussed about that. It is seen in rat models. So only thing is there's a risk of osteosarcoma, and that is seen only in patients with Paget's disease. Then Sinks index is useful in. So that is actually a very important screening tool for the diagnosis of again osteoporosis. It was actually named after Dr. Manmohan Singh, an orthopedician, and he only actually described the 6 grades. Normally, when you grade any uh, disease or anything, you start from actually 1 to 6 like that. But here it is graded from 6 to 1. That means actually 6 is normal here. That means there are actually 5 trabecular network around the neck of the femur. So first, this is the primary compression trabeculae. It starts in the calcar. The calcar is actually the medial part of the neck. So that is the strongest portion of the neck of the femur. There's very much cortical bone over here, and this is actually here you can see the primary compression trabeculae is actually radiating from the cortex and it's fanning out laterally. Whereas you can see another group coming from the lateral aspect and going medially. That is the primary tension. So here you can see the primary compression, and here perpendicular to the primary compression, here you can see the secondary compression, and this is the secondary tension, and this is the trochanteric. So all 5 are seen means grade 6, that's normal. So from grade 6 to grade 1, you can see there is loss. So in grade 5, the primary compression and primary tension are only seen. In grade 4, actually, you can see there is some attenuation of primary tension. And grade 3, the primary tension is broken. And in grade 2, actually, even the primary compression trabeculae are attenuated, and grade 1, even primary compression trabeculae are broken. That means grade 6 is normal, 5, 4, you can say osteopenia, and 3 to 1 is porosis. That's very important. That means 6 is normal, 5, 4 is osteopenia, and 3 to 1 is porosis. Then coming to and the next question is Garrod spars. Garrod spars are associated with which condition? It's commonly associated with Dupuytren's contraction. So Dupuytren's contraction, it's a very commonly seen in alcoholic patients, in patients on phenytoin, epileptic patients, patients with liver disease, cirrhosis, like that. So that's called Dupuytren's contraction. So it's nothing but usually, ring finger and little finger is commonly affected in Dupuytren's contracture. It is nothing but the fibromatosis of the palmar fascia. So there will be contracture, and patient won't be able to extend the IP joints and the MCP joints. That means the patient won't be able to keep the hand flat on the table. And there's a test called the tabletop test of Houston, where you ask the patient to keep the hand flat on the table. Because of the contracture, the patient won't be able to do. That's called the tabletop test of Houston, and that's one of the screening tests of Dupuytren's contracture. So it commonly affects the ring and little finger. It's a fibromatosis. Actually, it's a fibroplasia of the palmar fascia. So commonly associated with cirrhosis, alcoholics, patients on phenytoin, chronic smokers, like that. If it affects the fascia of the penis, it is called the Peyronie's disease. If it affects the plantar fascia, it's called Ladderhoff's disease. So in different sites, it's called different names. And the fibromatosis of the dorsal PIP joints, actually, they are called the Garrod nodes or the knuckle pads. So these are the Garrod pads. Actually, the dorsal aspect of the PIP joint will be fibromatosis, and that's called Garrod pads, and they are commonly associated with Dupuytren's contracture. So, coming to the next question, gamekeeper's thumb. So, gamekeeper's thumb injury is actually, gamekeeper means it's not associated with any game and all. It's actually a gamekeeper means a person who is a hunter who kills animals, especially rabbits and all. They kill by twisting their neck. So, when they do the twisting movement, they actually injure the thumb. So that's called the gamekeeper's thumb injury. And gamekeeper's thumb is actually injury to the ulnar collateral ligament of the MCP joint. So we will see this is the MCP joint, and here you can see that the ulnar collateral ligament. So there are two collateral ligaments for the metacarpophalangeal joint. One is the ulnar collateral and the radial collateral. So what happens when the hunter or the man tries to kill the rabbit by twisting the neck and all, they will try the will be abduction. There will be abduction or stretching of the thumb, and that will put stress on the ulnar collateral ligament, and it will get the patient will get complete rupture of the ulnar collateral ligament, and that is called the gamekeeper's thumb. And how do you clinically assess the injury? You actually abduct the thumb and actually look for tenderness over the medial aspect of the MCP joint. So here you can see that the radial collateral ligament of the MCP joint is intact, whereas the ulnar collateral ligament is totally torn, and you try to give a stress test by abducting the thumb. So this is a gamekeeper thumb. Then Thompson's test is used to diagnose. Thompson's test is actually same as Simmons test, where it's used to diagnose tendo-Achilles rupture. Closed tendo-Achilles rupture is becoming very common nowadays. Especially in ladies, especially if they are having dyslipidemia and hyperuricemia, if they are having some collagen vascular disorders like SLE, rheumatoid arthritis, and all, there can be fraying of the tendons. So even a very trivial injury can rupture the tendo-Achilles, especially squatting, even climbing stairs, that can rupture the tendo-Achilles. So even some drugs like what do you call the fluoroquinolones like pfloxacin, sparfloxacin, particularly sparfloxacin, it can actually cause damage to tendo-Achilles and can cause even spontaneous rupture, closed rupture of the tendo-Achilles. So Thompson's test is used to diagnose tendo-Achilles rupture, is otherwise called Simmons test. It's nothing but you ask the patient to lie prone on the table and try to squeeze the calf. What happens when you try to squeeze the calf? Normally, when you try to squeeze the calf, the angle will go into plantar flexion. But if there is a discontinuity over here, for example, if there is a rupture of the tendo-Achilles, even if you try to squeeze the calf, the angle will not move. So this is called Simmons test or Thompson's test. And radiologically, even from the X-ray itself, you can actually identify, even though you need a ultrasound or MRI, but still from the X-ray itself, you just remember there's a triangle at the posterior aspect of the angle that's called a Canker's triangle. It is actually bounded by anteriorly by the posterior border of the tibia, and base is found by the superior border of the calcaneum. And here you can see this is the tendo-Achilles at the posterior part. So here it is normal, and if it is broken, you can see there's a discontinuity. And that triangle is called Kagler's triangle. Then coming to Ober's test. Ober's test is particularly used in post-polio residual paralysis where there is contraction. Even though there is, what do you call, uh, paralysis of muscles in poliomyelitis, there will be contracture of IT band like that. So in Ober's test is used for contracture of the IT band. IT band is nothing but the iliotibial band. So what do you do here? Obese test means you ask the patient to lie on the sound side and you try to flex and abduct the hip joint, and you try, or no, normally what happens when you try to flex and abduct, it may fall. But what happens in IT band contraction, even if you do like that, the patient can be able to maintain the position like that, yeah, and it will not fall. And that is called Ober's test. That is used in IT band contraction. That means if the iliotibial band is contracted, what will happen? You can able to keep the hip and knee in the flexed and abducted position, and that is seen in usually in post-polio residual paralysis and all. So monophalangeal big toe is seen. That means normally you got two phalanges for the big toe, but if only one is present, that's called monophalangeal big toe. That means if the big toe is short, you have to diagnose this condition. That is called a myositis ossificans progressiva. See, actually, myositis ossificans progressiva is an older terminology, and the latest terminology is FOP, or fibrodysplasia ossificans progressiva. It's an extremely rare disease of the connective tissue, and actually, a mutation of the body's repair mechanism causes fibrous tissue, and including muscle, tendon, and even ligaments. When damaged, it will get ossified. That means whenever there is a damage to your tendon, muscle, or ligament, uh, actually it heals by actually ossification. There won't be any fibrosis, but ossification. So what happens? The ligaments, the joints will be frozen, completely permanently frozen in place. So here you can see some sheets of calcification around the spine, in around the joints like that. So you can see paraspinal calcifications, and you can see ankylosis of the joints, neck. So any injury to a muscle ligament will get the damage will be healed by ossification, and that's called FOP, or myositis ossificans progressiva. And don't think that this is same as myositis ossificans seen in trauma. This is actually a genetic condition, and the patient will have a very much bad disability with kyphosis, and the disability will be very severe. And here you can see the typical monophalangeal big toe. Here you can see a monophalangeal big toe as well as bilateral hallux valgus also. So this is called myositis ossificans progressiva, or fibro ossificans. So FOP. So the next question: a 20-year-old man was brought to the casualty with history of road traffic accident. He was diagnosed to have a type 2 open fracture of the right femur with a blunt injury abdomen and head injury. After stabilizing the vitals of the patient was posted in the emergency theater for the management of head and abdominal injury. What will be your orthopedic management? So remember, it's a polytrauma case, and the patient is actually having different head injury, abdominal injury, and an injury to long bone. So it's definitely a polytrauma case. And so what will you do? And it is not only a polytrauma, it's an open fracture also. It needs thorough debridement also. So it's called debridement. So even though you write it as debridement, you pronounce it as debrima. So upper tibial skeletal traction after thorough debrima, external fixator after thorough debrima, or even primary treatment or interlocking nail. So what will you do? Or plating. So the answer is actually you go for damage control orthopedics here. That means you want to save the life of the patient. Why? Because if you do the definitive procedure like interlocking nail after thorough debrima, there will be bleeding, and the patient may actually die. because it is a polytrauma case. So you want the life of the patient, so you do damage control orthopedics. You don't want to do again another damage to the patient, so you go for external fixation. So you do minimal invasive procedure, and after, of course, after thorough debrima. Okay, so it's a badly open fracture. You go for external fixator and actually stabilize the patient after proper thorough debrima. So basically, you should remember two types of management are there. One is ETC and DCO. ETC is nothing but early total care, and damage control orthopedics means that is seen only in polytrauma. That means early total care means if there is no polytrauma, if the patient is having an open fracture and all, definitely you can actually go for thorough debrima and interlocking nail and all. But if it is associated with the other injuries, definitely you go for damage control orthopedics. So, what is this damage control orthopedics? The first road traffic accident is the first hit, and even with the road traffic accident, there can be severe inflammatory response, and patient can go for multi-organ dysfunction and adult respiratory dysfunction like pulmonary embolism, fat embolism, like that. But what about your procedure? Your surgical procedure is actually a second hit, and that can again make the thing worse, and again that can go for more. So you should not give the second hit. In polytrauma and all, always go for damage control orthopedics. That means go for external fixators than internal fixation. Then coming to a splint, it is used in which it's called aeroplane splint. That means it looks like splint which looks like the wing of an aeroplane. So that is used in Erb's palsy. In radial nerve palsy, you use Cockup's splint, especially dynamic Cockup's splint, because in wrist drop you don't want to give contracture. To avoid contracture, you give wrist drop splint that's called Cockup's splint. In ulnar nerve palsy, there'll be clawing, and you give knuckle bender splint. That means knuckle bender means you want to keep the MCP joints flexed and IP joints extended. In claw hand, what happens? The MCP joint will be extended, and fingers will be IP joints will be flexed. So in knuckle bender, you keep the MCP joint in 90-degree flexion and IP joint in extension. So answer is palsy. Here you can see aeroplane splint where you keep the shoulder in abduction, especially in F palsy. The 5-6 root is involved F palsy, and clumkey is actually C8T1. The patient will be having a claw hand in clumkey's palsy. So what is the typical attitude in F palsy? Is a policeman or a waiter waiting for a tip, where that means the shoulder will be adducted, the elbow will be extended, and the forearm will be pronated, and the wrist will be flexed. So that is the classical C5, C6 route that is involved. Okay. The gallows traction is used for. Gallows traction is actually used for fracture shaft of femur in infants. That means the child will be actually hung with the buttocks elevated, and you give actually a frame so that you can keep the two limbs elevated. But the only thing is you cannot do it for fracture shaft of femur older than 2 years. Why? Because of vascular issues. Why? Because if you are hanging like this, definitely the blood flow to the distal part of the limb will be compromised, and that can result in decreased perfusion and all. So it is actually done for fracture shaft of femur in infants only. That means 1 year or less. Okay. In other words, it is also called Bryan's traction or gallows traction. Then another traction is called Dunlop traction. That is actually again a skin traction. A gallows traction is also a skin traction. Dunlop traction is given for fractures of the elbow joint, around the elbow joint, that is supracondylar fracture of the humerus, where you give Dunlop traction to correct the deformity. So it can also be given. So coming to some stress fractures, stress fractures are very common now because of vitamin D deficiency and all. A lot of adults are getting osteomalacia, and vitamin D deficiency is on the rise. Normal vitamin D level should be around 30 to 50 nanograms per ml. So, in vitamin deficiency and all, you get a lot of stress fractures. But here, these stress fractures are actually um, caused by repetitive trauma to normal bone. For example, in army persons and all, because of they're for 10 kilometers, 20 kilometers running and all, they get March fracture. March fracture is nothing but second metatarsal neck fracture. And clay shoveler fracture. Clay shoveler is actually, for people who try to shovel out the clay, and they actually flex the neck and extend that so that the C7 transverse process will be avulsed. Sorry, C7 spinous process will be avulsed, and that is called clay shoveler's fracture. And runner's fracture is actually lower third of fibula stress fracture, and jumpers is upper third of fibula, and ballet dancer is actually mid shaft of fibula. So this is the uh, thing. And so what is a stress fracture? Stress fracture is actually a fracture occurring a repetitive micro trauma. Remember, repetitive micro trauma occurring to a normal bone is called a stress fracture. In vitamin D deficiency and all, we get insufficiency fracture. Why? Because the bone is not normal. So March fracture, second metatarsal neck, and the clay shoveler is actually avulsion of the spinous process of C7, and runner is actually lower third of fibula. Jumper's fracture is upper third of fibula, and ballet dancer is mid shaft fibula. Then dances, they get a mid shaft fibula fracture. So here you can see a beautiful callus over the second metatarsal is actually healed. You can see there is a lot of abundant callus also. So whenever you see such a sclerotic thing on the bone, you have to actually rule out osteosarcoma as well, right? Because osteosarcoma is a very important differential of uh, stress fracture also. So whenever you suspect stress fracture, you have to rule out osteosarcoma as well. So anything can be anything. So just you cannot say it as stress fracture from the X-ray, but you have to rule out osteosarcoma also. So most common cause of a pathological fracture. Even though metastatic bone disease is the most common malignant bone tumor, most common cause of a pathological fracture is actually osteoporosis. Majority of the fractures after 50, 60 years, we get Colles fracture, trochanteric fracture, fracture of the neck of femur, anterior vertical compression fracture of the spine, vertebral compression fractures. These are all caused due to osteoporosis. Actually, Colles fracture is the fracture of the distal of the radius. It's actually a warning sign or a red flag that the patient is having osteoporosis. So that you have to treat the osteoporosis and prevent a trochanteric fracture or a neck of femur or a peritrochanteric fracture in future. So the answer is osteoporosis. So gunstock deformity is seen as a complication of it looks like the elbow looks like the gun stock. That is classically seen in malunited supracondylar fracture of humerus, as well as in medial epiphyseal injury also. So answer is both A and B. What happens in the medial epiphyseal injury? The growth of the line of growth of epiphysis. The medial epiphysis anywhere in the body will grow laterally, and the lateral epiphysis will grow medially. That means the medial epiphysis of the elbow will actually it goes laterally, and lateral will grow medially. So if there is an arrest or injury to the medial epiphysis, the medial will not grow laterally, and the lateral will relatively overgrow medial. That means whenever there is injury to the medial epiphysis, the resulting deformity will be a cubitus varus. Whereas if there is an injury to lateral epiphysis, the medial will overgrow laterally, and the resulting deformity will be a cubitus valgus. Likewise. So in supracondylar fracture, the patient will get a cubitus varus, and it looks like a gunstock. And middle epiphyseal injury will also cause a gunstock deformity. And this is actually a cubitus valgus. What is the normal Carrying angle is around 5 to 10 degrees in males and around 10 to 20 degrees in females. Females like Q angle, their carrying angle is also more. Why? Because they want to, because of the wider pelvis. They want to accommodate the wider pelvis, they need a wider carrying angle. So, what are the causes of cubitus valgus? The most common cause of cubitus varus is malunited supracondylar fracture, whereas the most common cause of cubitus valgus is non-union of lateral condyle. Lateral condyle fracture is one of the no fractures of necessity. That means it is actually a fracture of necessity. Means there is no role for conservative management. You have to surgically uh, manage the patient. You have to go for open reduction. Otherwise, it is an avulsion injury of the cartilage of the distal humerus. So what happens? The cartilage will be turned inward. So cartilage is avascular. So it will be it will be in contact with the bleeding bone. So it will never get united. So you have to derotate it and fix it with K-wires. So that means there is no role for conservative. There is no role for weight and loss. So next cause is lateral epiphysis. That we already discussed. When the lateral epiphysis is injured, what happens? The medial epiphysis will relatively overgrow lateral. So the resulting deformity will be cubitus valgus. Then very rarely, posterolateral type of supracondylar fracture can also cause cubitus valgus. Why? Because most common type of supracondylar fracture is posteromedial type, and that will cause cubitus valgus. Here it is very rare posterolateral. Then bilateral cubitus valgus is seen in congenital Turner syndrome. Okay, with streak ovaries, exo, you will get cubitus valgus bilateral. And tardy ulnar nerve injury occurs in cubitus valgus. What is the word meaning of tardy? Means late. So what happens in cubitus valgus? A progressive cubitus valgus, what will happen? The ulnar nerve on the middle side will get stretched. So stretching will result in axonotomesis, and that will cause ulnar nerve injury. So next question is, Steinman pin is used in skeletal traction all sides. Usually, when we postpone the case, when the patient, especially if you don't go for ETC, and that means early total care, you may give traction to the patient. And for that, you use Steinman pin. And that is usually used in upper tibia, lower tibia. You can use it in calcaneum, you can use it in greater trochanter, but not in fibula. So fibula is not the side. So here you can see this pin. The name of this pin is called Steinman. It was described by Fritz Steinman. And that is used in skeletal traction. So, and the name of the stirrup is called Bowler's stirrup. And actually, the whole limb will be kept on a frame called BB splint. And you should know about how much weight that is attached to skeletal traction. It's actually 1/10 of the body weight. So, that means the patient is having 70 kilos, you can attach 7 kilos weight. And you should know how much the limb is elevated also. The foot end of the limb is elevated for each. For 1 pound, you elevate by 1 inch. That means why you want to elevate the foot end of the bed in skeletal traction? Because if you want to, when you elevate the bed, what will happen? The whole body weight will act as what do you call a counter traction by gravity, and the weight will act as traction. So this is a skeletal traction. So Hütter-Volkmann's law is related to. So actually, it's a law based on compression distraction to the cartilage. That means any compression injury to the cartilage will inhibit the growth, and distraction or lengthening of the cartilage will actually stimulate the growth. So that's called Richard von Volkmann's theory, the Hütter-Volkmann's law. It states that any compressive force, any compression will inhibit the growth of the cartilage, and any tensile force or distraction will stimulate. So the classical example is Blount's disease. You might have heard of infantile tibia vera. Especially in chubby children, obese children, what happened in early walkers also. If the child is very chubby, very obese and early walkers, what will happen? There'll be more of compressive force. More compression will be on the medial aspect of the growth plate, and that will cause growth arrest. So that will cause. So when the middle part of the cartilage is affected, what will happen? The lateral will try to grow medially, and that will result in tibia vara. So the classical example is Blount's disease and Wolff's law. That's actually the Julius Wolff, the German, that is related to bone. It states that bony trabeculae are laid along the line of stress. That means, how will you give stress to the bone? By muscle pull. That means if you are not using your muscles, your bone will be weak. That means there is no point in pumping in calcium additives, especially in elderly, in osteoporosis, unless they do exercise. So the importance of exercise is actually uh, uh, explained by Wolff's law. That means the more you give stress to the bone, the more trabeculae will be laid. And so that is by aerobic exercise, contact aerobic exercise, like running, walking, jumping, like that. And pseudex osteodystrophy is actually seen due to Wolff's law. That means if you are not using your limb, what will happen? There will be decalcification of the bone, and that is called regional osteoporosis, again based on Wolff's law. The Leeford-Wagstaff, that is a eponymous fracture that is named after a person, Leeford-Wagstaff. It actually is an epiphyseal injury that is seen in children, that is affects the lateral malleolus. You know, ligament injury is very rare in a child, whereas ligament injury is very common in an adult. You know why? And bony injury is very common in a child, and bony injury is rare when you compare with ligament injury in an adult. Why? Because uh, in a child, bones are very soft, but ligaments are so lax and elastic that can extend to any extent. So here you can see the anterior tibiofibular ligament. The ligament as such is not torn, but it has come off with a piece or a chunk of cartilage and bone. And this is called the Leeford-Wagstaff fractures. This is nothing but the middle part of the fibula is actually fractured. And the counterpart of the Leeford-Wagstaff, that means if the tibial side is actually fractured in children, it is called a Tilloch's fracture. So Tilloch's fracture and Leeford-Wagstaff fractures are actually seen in children, and it's because of the avulsion of the anterior tibiofibular ligament. Then coming to the next question, the most common site of bipartite patella. You know, the word itself is self-explanatory. Bi means two, partitate means two pieces. You know, patella is ossified from numerous ossification centers. And one more thing to remember is the blood supply comes from distal to proximal. And the most common site of bipartite patella is superolateral. So the importance is that we often mistake it as a fracture. And I have seen many surgeons fixing it also. Why? Because you have to differentiate it from a normal, from a fracture. In fracture, the ends won't be rounded off and smooth. In fracture, it will be very sharp. And not only that, the patient will be having pain. And the take-home message is don't treat X-rays, you treat the patient. That means you have to see the patient clinically and assess. So this is actually a normal variant. It's otherwise called a don't touch lesion. You should not touch. That means there is no role for surgery. So this is called actually called a bipartite patella. And the classical location is superolateral. That means around 80% of the bipartite patellae are seen in the superolateral quadrant. And not only that, if you see a bipartite patella, actually 50% are bilateral also. So remember, 50% are bilateral, and 80% of the cases are seen in the superolateral quadrant. And the most common cause of recurrent dislocation of patella, we have already studied about the Q angle, the recurrent dislocation of patella. So the most common cause is patella alta. The word alta means high, altitude, high riding patella. So in high riding patella, how will you radiologically assess the patella alta? Means the patella will be riding high. That means if you take the ratio of the ligamentum patella to length of the patella, definitely this part will be more. So that means the LT, if you divide normally by the length of the patella by ligament of patella, it will be 1. But what happens in patella alta, if you divide the length of the patella by length of the patella tendon, it will be less than 1. So that is called patella alta. The patella is lying low, it is called patella baja, but it is written as BAJA. If the patella is riding high, it is called patella alta. And remember, patella alta is the most common cause of recurrent dislocation of patella. So, what are the predisposing factors? We already discussed patella alta, genu valgum, then hypoplasia of the lateral condyle of femur, then tight lateral structures, then lax medial structures, excessive femoral version, then hypertrophy of lateralis, like that. Then Fairbanks test is used in the diagnosis. Again, Fairbanks test is again a test used in the diagnosis of recurrent dislocation of patella. So this is the test. You ask the patient to keep the knee at 30 degrees and you try to push the patella laterally, and the patient will actually resist your test because of there will be apprehension. The patient will think that you are going to dislocate the patella and you will try to resist. You can see the patient's face. The patient will be having severe pain, and that's called apprehension test or Fairbanks test. So other Fairbanks or the Fairbank triangle is in congenital coxa vara. That means there will be a growth defect in the infromedial aspect of the femoral neck. So I already told about the line of growth of the direction of growth of the physis. When the infromedial aspect of the femoral neck is if there is a defect, what will happen? The supralateral will overgrow more medially. So resulting in coxa vara. So there is a defective growth in the infromedial aspect. Then Fairbanks disease is nothing but multiple epiphyseal dysplasia. That means the epiphysis will be having defective growth, and the patient will be short-staged, and the limbs will be having shortening of the limbs. That's called Fairbanks disease. Then the most common site of osteochondritis dissecans. You know, osteochondritis dissecans is actually again a avascular necrosis of the cartilage of the knee joint. It is commonly seen, around 80% of the lesions are seen near the PCL attachment. You know, when the posterior cruciate ligament attachment is seen near the medial femoral condyle. So the answer is medial femoral condyle. So even though the etiology of OCD or the osteochondritis dissecans is controversial, it appears to be traumatic. Usually there will be a history of a trauma, and that will cause interruption of blood supply. And most common sites are medial femoral condyle, patella, like that. Lateral femoral condyle and patella. So 80% of the lesions are classically in the medial femoral condyle on the posterolateral region, that is classically near the posterior cruciate ligament area, and 15% will be seen near the lateral femoral condyle area near the ACL, and only 5% will be seen, or 5 to 10 in the patella region. So here you can see looks like a loose fragment in the knee joint, or otherwise called a loose body in the knee. Actually, it's nothing but the you can see it is in the medial femoral condyle. This is a classical osteochondritis dissecans, and this is actually the notch view, where you can beautifully see the notch of the femoral condyle. So here you can see a portion of the cartilage being avulsed, and this is maybe due to trauma, and that causes a vascular necrosis. Then this is a special nail used in the treatment of, that's called a recon nail, that is used when there is an associated injury of neck as well as shaft. So the important thing here is the patient is having an ipsilateral neck as well as a shaft. That means we may actually overlook the neck of femur injury if the patient is having shaft of femur. So the incidence of a neck of femur with the shaft is around 6 to 12%. That means it's not that uncommon. So whenever if the patient is having fracture shaft of femur, you have to rule out neck of femur also. And this is one of the implants used to treat ipsilateral neck and shaft. That means you can treat it with a recon nail is a reconstruction nail. So short form is recon. The full form is reconstruction nail, where you address the neck of femur fracture through these two screws, and you fix the fractured femur with the nail and screws. Nowadays, we actually use two different implants. Why? Because if the thing fails, both the fractures will not unite. So we usually address the neck of femur with a separate implant and shaft with a separate implant. So flowing intervertebral ossification, flowing wax appearance is actually seen in Forrester's disease. So this is called a dish. Dish is nothing but a diffuse idiopathic skeletal hyperostosis characterized by osseous proliferation and manifested by bony spur bridges, especially in the anterior longitudinal ligament. So it looks like a flowing intervertebral ossification, and it's called a Forrester's disease. So here you can see this is the normal anterior longitudinal ligament, whereas here you can see flowing flowing anterior longitudinal ligament calcification, and that is seen in dish of Forrester's disease. So here you can see bamboo spine, typical bamboo spine. These are all syndesmophytes with something like bamboo spine, and that is seen in ankylosing spondylitis. So bamboo spine is seen in ankylosing spondylitis, whereas flowing intervertebral ossification is seen in Forrester's disease or dish. So both are different, even though you may look at it as even though it looks same, almost same, and these are entirely different. So here you can see something like a bamboo spine due to bridging osteophytes, whereas in Forrester's disease, that is ossification of the anterior longitudinal ligaments. Here it is actually syndesmophytes, bridging syndesmophytes. It looks like bamboo spine. So congenital pseudoarthrosis of the tibia is associated with. So it is associated with actually fibrous. It's a very rare disease, but it's very difficult to treat also. Congenital pseudo means false joint. Pseudo means false, and arthrosis means a joint. So it's a false joint. It's actually an end result of a non-union, but the thing is, it is not like a traumatic non-union. It's due to neurofibromatosis or fibrous dysplasia, and it is very difficult to treat also. So it is associated with fibrous dysplasia as well as neurofibromatosis. So here you can see there is a big gap between the two bones, the tibia, and this is called pseudoarthrosis. And the thing is, child will be having a short limb, and it's very difficult to treat also, and the chance of recurrence is also very high. And we often see association of fibrous dysplasia as well as neurofibromatosis. And you can see two types of cafe au lait. Cafe means coffee, o means own, lait means milk. Coffee on milk appearance. Here you can see cafe au lait, which looks like an irregular jagged appearance. Here you can see smooth round. So this type of cafe au lait is called the coast of Maine, and a smooth round border is called coast of California. So coast of California is actually seen in neurofibromatosis, and coast of Maine is in fibrous dysplasia. That means it looks like the coast of Maine in United States. Here also, this looks like the coast of California in the US. So remember, coast of California is very smooth, and it is seen in neurofibromatosis, and Maine is seen in fibrous dysplasia. So omovertebral bone is seen. Omo means, the word means shoulder. Vertebra means, of course, the connection between the shoulder to cervical vertebra. It's actually seen in Sprengel's shoulder. Sprengel's shoulder is nothing but a congenital elevated scapula. It's a very, very rare disorder, and you see once in a blue moon. Last week I saw a child with Sprengel's shoulder. It's nothing but a congenitally elevated shoulder. During embryonic development, during the development of the fetus, in utero development, normally there should be a descent of the scapula. If that is not happening, the scapula will be congenitally elevated, and that's called the Sprengel's shoulder. It is actually associated with omovertebral bone, and actually, it is associated with a lot of other conditions like congenital scoliosis, Klippel-Feil syndrome, block vertebra, like that. So here you can see this shoulder is actually elevated and the scapula is riding high. And on the 3D CT also, you can beautifully appreciate the high riding scapula or the congenitally elevated scapula. And radiologically, you can see something like a special bone called the omovertebral bone, which actually bridges the cervical vertebra with the shoulder. That's called an omovertebral bone. Which of the following is not a packaging disorder? That means the fetus is being packed inside the uterus. If the room of the uterus is very less, for example, there is a multiple pregnancy, twin pregnancies, oligohydramnios, if there is no enough room for the fetus to move around, you will get this packaging disorder. So a lot of conditions are grouped under packaging disorder. They are called the CTV or the congenital talipes equinovarus or clubfoot, then congenital metatarsus adductus, then congenital dislocation of the hip joint, then metatarsus adductus. So answer is actually none. So here you can see that in utero, there is no enough room for the child to move around. We'll get all the packaging disorders. Then wooden doll facies. That means expressionless facies is seen in which condition? That's typically seen in arthrogryposis multiplex congenita. The word itself is self-explanatory. Arthro means joint, gryposis means crooked, multiplex means multiple, and congenita means bypass. That means multiple congenital contractures of the crooked joints. There are two types of, the newer terminology is not IMC, it is MCC, multiple congenital contractures. There are two types, neuropathic and myopathic. And there will be joint contractures, and there will be actually hyperextension of the elbows, flexion deformity of the knees, and there will be even thumb in hand deformity. There will be flexion of the wrist like that. So here you can see a lot of deformities, especially hyperextension of the elbow, flexion of the wrist. Typically, there can be thumb in hand deformity. There can be associated clubfoot, very severe form of clubfoot, even with very severe form of congenital dislocation of the hip joint, flexion deformity of the knees, hyperextension of the elbows, like that. And typical deformity is thumb in hand deformity, like that. Then Bowler's thumb is seen in. Bowler's thumb, in Bowler's, there can be undue friction of this nerve, and that can cause perineural fibrosis. So typically the ulnar digital nerve, the thumb, the median nerve divides into the medial and the lateral half to the thumb, and it is actually the ulnar digital nerve. Ulnar digital nerve is nothing but the branch of the median nerve to the thumb, and that can get fibrosis. So perineural fibrosis of the ulnar digital nerve, the thumb, is called a Bowler's thumb. So the ulnar digital nerve is involved. Then McMurray osteotomy. It was not done nowadays. It is actually just a historical importance. It was actually done for intracapsular fracture neck of femur. So that's called an osteotomy called McMurray's osteotomy. Is actually a subtrochanteric osteotomy, which is done to convert a shear force into a compressive force. That means in fracture neck of femur, the fracture line is actually vertical. So by doing the osteotomy, you are shifting the line of fracture from vertical to transverse. So if the fracture line is vertical, the force acting will be shear. If it is transverse, there will be compression. So this is the typical McMurray's osteotomy, whereas where the distal fragment is medialized and giving an armchair effect to the neck of femur, and you are actually converting the shear force into compressive force. So this is done for fracture neck of femur. The locking compression plating. It's a recent advancement in plating. In olden days, we used to do dynamic compression plating, but recently locking compression plating has come. That is used in open and osteoporotic fractures, periprosthetic and periarticular. So answer is actually all the above. Actually, this is the plate The locking compression plate means the screws, this is ordinary screw, where here you can see the locking screw, where there are threads over the head of the screw, which will lock with the threads in the hole, so that even if the screw comes off the bone, the screw will never comes off the plate. It's a very stable construct, and it is actually the implant of choice in osteoporosis. Osteoporotic fractures, periprosthetic and periarticular. So that is called LCP. So not only that, here you can see there is some undercutting of the plate, so that the periosteal blood supply is compromised. Here you can see when you put an ordinary plate, you are actually disrupting the periosteum. But whereas in LCP, in some areas, the plate is not actually flush with the bone. In those areas, they are actually saving the blood supply to the bone. So the periosteal blood supply is saved. So JUS is actually a type of external fixator. Just stands for Joshi. Joshi is the name of an Indian orthopedician. Is actually the first MS Ortho student in India. BB Joshi from Mumbai, Brij Bhushan Joshi, and he is actually a pioneer in the hand surgery, and he is the one who devised many external fixators, and it is not indicated. Actually, Joshi's external stabilization system is actually indicated in neglected CTV, intra-articular fracture of the distal radius. This fixator actually works on the principle of ligamentotaxis. What is ligamentotaxis? Means when you stretch the ligament, the bones which are attached to ligaments will also get aligned. That's the principle of JUS. So that is not indicating die punch fracture. What is die punch fracture and die punch? Where is the die in the wrist is lunate bone. So that the lunate is going to give a punch to the radius, and actually a part of the intra-articular portion of the lunate fossa, which is the quadrangular fossa, is being pushed in. So there is no ligament as such attached. And if when you do JUS, you cannot correct this displacement. You have to manually open it. So JUS is not indicated in die punch fracture. Whereas, this is a JUS fixator used in clubfoot or CTV, where you actually lengthen the both medial and lateral, but medial is more lengthened than the lateral, so that the foot length can be increased and the varus can be corrected. So die punch is actually caused by impact of lunate into the lunate fossa. There are no ligaments attached for that displaced fragment. So no role for JUS. So it talks on the principle of ligamentotaxis. When ligaments are stretched and aligned, the bones that are attached to them will also get aligned. So ender nail is used in fixing fracture of all except. Ender nail, again a historical question. It is not used nowadays. It was used, the name of a person is Ender. It was used for fracture fixation of humerus. It can be used for tibia, but not for ulna. So you can see here, you can see multiple ender nails used in even in femur, tibia, humerus, like that. So coming to amputation, destructive surgery. Nowadays, we seldom do amputation. We always try to salvage the limb. So Gritty-Stokes amputation is actually a transcondylar femoral amputation. That means the removal of the limb is done through the femoral condyles. That is called Gritty-Stokes. So at each level, you have got different names. This is a right start from hemipelvectomy, hindquarter, hip disarticulation means you have removed the limb through the joint. You know what is disarticulation? Disarticulation is the removal of the limb through the joint, whereas amputation is removal of the limb through the bone. And actually, Gritty-Stokes is through the transfemoral, and Symes is through the ankle, and Boyd's is through the calcaneum, and Chopard is through the Chopard's joint. You know where is the Chopard's joint? Chopard's joint is the mid-tarsal joint, actually the talonavicular and the calcaneal cupoid. And the Lisfranc's joint is actually the tarsometatarsal joint. Then Krukenberg amputation. It's a peculiar type of amputation done in forearm amputation, where actually the radius and ulna can be used as to hold the objects, glass, like that, like the two prongs of a forceps. So this type of amputation is called Krukenberg amputation. Then Kramer wire. Actually, Kramer wire is not used for internal or external fixator. It is just used in first aid. It is actually a splint for immobilizing the bone while transporting the patient. So it's a splint, like the Thomas splint and all. It's just a splint. It's called a Kramer wire, just for splinting and doing the first aid only. Then Charlie's compression arthrodesis is used in. You know what is arthrodesis? In the intentional surgical fusion of a joint is called arthrodesis, and Charlie is actually credited with the first arthrodesis. And they use clamps to compress the bone so that there will be fusion of the joint. And most common indication of arthrodesis is osteoarthritis, especially in the ankle joint, and it can be done in knee joint also if there is a failed arthroplasty or if there is an infection following arthroplasty and all, you can do arthrodesis. But the disadvantage is the patient will lose movement, and definitely pain will be completely subsided, but at the cost of mobility. So angle is, and so the answer is both knee joint and ankle joint. So here you can see a compression arthrodesis of the knee joint. Here you can see Charlie's compression clamp. You tighten the clamp till the wire bends. You can use K-wire or Steinman pin, whatever. The mobile wad of Henry consists of all except, it's actually an anatomical question. It's, there are 20 muscles in your forearm, and there are 4 compartments in your forearm, the superficial and deep flexor compartment, the mobile wad of Henry, and the dorsal compartment. The mobile wad of Henry actually houses extensor capitalidis longus, extensor capitalidis brevis, and brachioradialis. So 3 muscles are grouped in mobile wad of Henry, not FCU. So 4 compartments in the forearm: the superficial volar, the deep volar, dorsal, and mobile wad of Henry. Actually, dorsal 8 plus the volar 12, including the mobile wad of Henry. And the importance is the deep volar compartment comprising the FDP and FPL are commonly involved in compartment syndrome. So the muscles paired in lead palsy. Lead is commonly seen in paints, in petrol, like that. But nowadays we get non-leaded petrol and all. But the most common source of lead is now Chinese toys, soft toys like that. They contain a lot of lead. And lead causes radial nerve injury, wrist drop. But specifically, one thing to remember is it typically spares the brachioradialis. So the muscle spared in lead palsy is brachioradialis. So the most common cause is now Chinese toys. They are flooding the market, and that will expose the child to lead. So pseudo fractures, or otherwise called insufficiency fractures. Actually, they are called loser's zone also, because it was described by a person called a loser, or even otherwise called milkman's line. So remember, milkman's line, pseudo fractures, insufficiency fractures, loser's zone, LOSER, they're all one and the same. And they are actually radiolucent lesions surrounded by sclerosis, commonly seen along the axillary border of the scapula, around it can be seen in the ribs, in the superior inferior pubic rami, even in the femoral neck, or even in the ulna also it can be seen. So it is actually seen in osteomalacia, vitamin D deficiency rickets, and even in osteogenesis imperfecta, fibrous dysplasia, like that, but not in osteopetrosis. So actually, this is osteopetrosis, where you can see bone-in-bone appearance. Os in os appearance is also seen because it looks like a marble bone. This disease is called marble bone disease or osteopetrosis. It's actually a disease of osteoclast. So there is a carbonic anhydrase deficiency in osteoclast. So osteoclast won't be activated. So whatever bone that is deposited, it won't be eaten away by the osteoclast. But even though the bone looks like rock hard, it is brittle. So there can be pathological fractures, but pseudo fractures are not described. So this is osteopetrosis. Then fish mouth vertebrae are seen in all except. That means the vertebrae looks like the fish mouth. That's classically seen when the bone is weak in osteoporosis, osteomalacia, even in sickle cell disease, but not in hypoparathyroidism. Why? Because in only in hyperparathyroidism the bone is weak. The reverse is true in hypoparathyroidism. So answer is not in hypoparathyroidism. So this the vertebra is actually looks like the ends of the vertebra looks like the fish mouth. That means you see something like a biconvex or ballooning of the intervertebral disc and biconcave vertebra. So this is the fish mouth. It is classically described in osteomalacia, osteoporosis, like that. Then we come to the last question. The Shawber's test is used in. Shawber's test is actually used in ankylosing spondylitis, whether it's a disease affecting the young males which causes ankylosis of the vertebra, sacroiliac joint, like that. And it usually limits the flexion of the spine. That's very important. So flexion of the spine is actually measured by using this Shawber's test, where you keep a flexible measuring tape around 10 centimeters from the dimple of Venus. This is the dimple of Venus or the posterior superior iliac spine, and you mark a position on the especially on the 15 centimeter mark, and you ask the patient to bend the spine forwards, and you just measure the excursion. Normally, it should be around 6 to 7 centimeters. If the excursion is less than 5 centimeters, that means the flexion of the spine is affected. Usually, the flexion is more at the lumbar spine, and that's why you look at the lower part of the spine, and that's called Shawber's test. And in ankylosing spondylitis, we have to measure the chest circumference, the chest expansion also. And if it is less than 2.5 centimeter, again, it is diagnostic of ankylosing spondylitis. With that, I think we have come to the end of this session.